The broadcast is now starting. All attendees are in listen-only mode.
Good evening and welcome to Reproaction's February 2018 Act and Learn webinar. Tonight's topic will be informative and interesting. It is yearly exams, taking control of your reproductive health care. So first, let's kick off with your hosts. You are talking to the co-founders and co-directors of Reproaction. The first voice you hear is myself, Erin Matson. I'm based in Arlington, Virginia, just outside of Washington, D.C.
And I am Pamela Merritt. I'm the other co-founder and co-director of Reproaction, and I am based in St. Louis, Missouri.
Great. So let me lay out a quick agenda so you can see where we're headed tonight. We'll introduce Reproaction, then we'll start keeping it real about yearly exams, do an overview. We'll do a Q&A with a panel discussion with Dr. Colleen McNicholas. Then we'll do a panel discussion with Cicely Paine from our advisory council, who we're very excited to have joining us tonight. We'll do next steps, and then we'll do Q&A with panelists from the audience. So if you have questions at any time during this presentation tonight, just put them into the chat box and we'll get to as many of them as we can at the end. And we encourage you to live tweet if you wish. The hashtag that you can use is #ReproAction. So first, a quick note about Reproaction. Reproaction is a new direct action group forming to increase access to abortion and advance reproductive justice. We're incredibly proud of our left flank analysis. We are known for our willingness to hold folks on all sides of the issues accountable, whether they are traditionally considered political allies or political opposition. We also have a deep commitment to nonviolent direct action as one of the tactics and tools that we use. And with that, I'll pass it to Pamela.
Thank you so much, Erin. So I came up with the idea for this Act and Learn webinar after watching a commercial on television that was targeting women who experience endometriosis, which is a not uncommon reproductive health issue and can be extremely painful. So I myself experienced endometriosis and fibroids throughout my life, and this commercial really kind of captured my attention. The thing that was really interesting about the ad is that it spoke to people who were experiencing endometriosis, but who were reluctant or nervous about talking about their symptoms with their provider. And it really hit me close to home that so many people are not quite sure how to start conversations with their provider or what's appropriate. And in my own personal experience, I got caught up in the what's normal kind of cycle, not even knowing if it was something worth being worried about. So I started thinking about how to become an empowered patient and how to approach your yearly exams with questions, but also in a way to get the most out of it, and also get the questions that you might be a little reluctant or unsure to ask answered. I also thought through how to kind of plan for the questions that your provider might have for you when you go in for your yearly exam. And out of that, this webinar was born. Next slide, Erin. So common questions that often are asked by providers during your yearly exam actually give us an opportunity to think through ahead of going into the doctor's office so that we can be prepared to answer these questions with as much detail as possible. And again, the more information that you give your healthcare provider, the more that they can help you understand how to take control of your health and also understand what to be worried about and what not to be up late at night searching WebMD about. So some common questions that are often asked during yearly exams: are you experiencing any health problems? Again, this is an opportunity to talk about problems that might involve, a racing heartbeat, or problems that might be specific to your menstrual cycle or sexual health. Another common question is, what was the date of your last period? I remember when I would go to the doctor and I could not answer that question. So it's actually not a bad idea to, again, prepare for that question. How long does your period typically last? Is it heavy or light or medium? And do you have cramps? And how would you describe those cramps? Another common question is, what is your family's medical history? And that one always was a tough one for me. I come from a family that doesn't disclose medical history until you say you've got something. So if you say that I told my aunt I had high blood pressure, and all of a sudden I found out that that is common in my family. So again, this is not something that you might be thinking about on a daily basis, but as you prepare for your yearly exam, it's not a bad idea to reach out to some family members if you're able to and just ask them about any things that run in the family. Do you take any medications, any vitamins, any herbs or supplements? Or do you use tobacco, alcohol, or other drugs? This is where it's important to be honest, but also to acknowledge that there can be some shame that is associated from the medical community. Not all doctors and providers do this, but that you want to be as honest as possible because you want to be able to give your healthcare provider the best outlook and vision of where you are health-wise. Are you sexually active? Do you use birth control? Has anyone forced you to have sexual activities that made you uncomfortable? Do you ever feel sad or depressed as though you have nothing to look forward to? Those are questions that you might not think that you get asked at a yearly exam, but they're important questions that help your provider give you advice, give you support, and maybe even give you resources to address other health concerns that you're experiencing in your life. So this is just a basic list. I know that our panelists are going to go into more specifics, but these are some common questions that you might want to take a look at and kind of prepare for before you go in for your yearly exam. Erin?
All right, thank you very much, Pamela. So now I'm pleased to introduce Dr. Colleen McNicholas. She graduated from the A.T. Still University of Health Sciences Kirksville College of Osteopathic Medicine in 2007. She works in St. Louis, Missouri, and one other location and specializes in obstetrics and gynecology. Dr. McNicholas is affiliated with Barnes Jewish Hospital, Missouri Baptist Medical Center, and St. Louis Children's Hospital. She is an abortion provider at Reproductive Health Services St. Louis, Planned Parenthood Columbia, and Trust Women in Wichita and Oklahoma City. Dr. McNicholas, thank you for your work and thank you for joining us tonight.
Happy to be here.
Great. All right, well, let's dive right in. I've got a ton of questions for you, so let's go. First question is, so can you tell us what can patients expect during a well woman exam?
Yeah, so it's a great question, and the truth is the answer is really varied. The well woman exam is really the patient's opportunity to address any number of things. When I think broadly about the well woman exam, I think of two sort of big categories. The first is preventative care. For many women, the gynecologist is their only physician until later in life when they have other medical issues come up. And so in that instance, it's really important to think about things like, for example, cholesterol or diabetes screening. The other big bucket I think about is anything and everything that has to do with sexual and reproductive health. And the truth is that what the well woman exam looks like is really different, mostly based on age. So for example, my adolescent patients, I spend most of that annual exam talking about sexuality, talking about consent, talking about what is sex, right? And that's a very different annual exam than, say, my 30-year-old woman who is already sexually active and has had other life experiences. So the bottom line is this: you should take this opportunity to get whatever questions you have answered in that really broad stroke of anything from prevention to anything and everything reproductive and sexual health.
Great. Thank you, Dr. McNicholas. And thank you for shedding light on why I get my cholesterol taken at my OBGYN. Now I'm like, oh, that makes so much sense. So it's great to hear that. Okay, so another question I have for you is how much information or how many details about things like periods, sexual history, and general health are helpful for patients to share during a well woman exam? So how much detail should we be providing? Should we be concerned about overshare or undershare?
Well, I will tell you, as a gynecologist, I feel like there's no such thing as overshare, right? And I will tell you that if your physician or your clinician is approaching this visit in the way that's going to optimize your healthcare, it doesn't take actually very many questions for us to figure out where more probing needs to happen. So, you know, Pamela presented a great set of sort of baseline questions that we ask everybody. And from those answers, that helps me sort of guide what further information do I need from patients. Having said that, I always encourage patients that if there's something else that I have missed or I haven't touched on that's bothering you or you want to talk about, you should always bring that up regardless of whatever line of questioning that I sort of bring you down.
Great, thank you. That's helpful. So another question I have is, should patients ask about STI or sexually transmitted infection and HIV testing, or is it standard or offered proactively by the OBGYN during well woman exams? And I ask about this in part to knowing that this is something that's stigmatized to ask for. So is this something that people should be proactively asking for? Should they be embarrassed about it or see it as outside of the realm of what's normal?
You know, it's interesting. So STI health is, from my perspective, as sort of a steward of public health, it's really a prevention measure. You know, there's a couple of different approaches that I think are taken in medicine. And the truth is, no approach fits 100% for each patient, right? So there is the approach that I'm going to offer STI testing to every single patient because I'm not going to make any assumptions about their risk factors. And that's sort of in that approach, we probably are screening too many people. There's an approach where I'm only going to test people who I feel like are at risk. And there's a lot of potential downfall in that approach because what we'll see is a provider's own bias in determining who they think is at risk for STDs. Probably the best approach is a combination of those two extremes. So the CDC does recommend that everybody under the age of 26 get annual gonorrhea and chlamydia testing. It doesn't make recommendations about the other STD testing, and so those should really be based on a person's risk profile. You know, if they have a partner who is HIV positive, I would say they probably need annual HIV testing. People who are drug users, IV drug users, for example, or sex workers, those are people who we screen more frequently. But not everybody needs every STD testing every time they go to the gynecologist. It really needs to be sort of a tailored approach to what their sexual behaviors are and honestly what they are interested in. At no point should anybody ever be tested for an STD without giving permission for that first.
That's great, and that's really good to hear the affirmation of consent coming from you. I think that's valuable for everyone to hear on this webinar, particularly from a reproductive justice perspective. So turning to a different question. So recently, as people are well aware, with the Me Too movement, there was an article that came out about Aziz Ansari that led to a number of different responses, and one of them was an amazing piece in a publication called The Week that was focused actually on the very high proportion of women who experience pain during sexual intercourse, and that's not something that is often talked about. And so in particular, I wanted to ask, what advice do you have for patients on how they share information about pain they're experiencing during vaginal intercourse in particular?
Yeah, so another great question, and it's one of these things, as Pamela alluded to earlier, where even within gynecology, there are specific sort of diagnoses that we really struggle with. One, assuming that some level of it is normal when it's not. And two, some real shame and stigma about talking about some of these things. And pain with intercourse, and the sort of medical terminology for that is dyspareunia, is one of those very things. So, every clinician approaches this a little bit differently, but in my practice, what I do is every single time I see somebody, I assess their sexual behaviors every single time, making no assumption that, whether they told me they were married in a monogamous heterosexual relationship last time, I'm not going to assume that that's the same thing this time. And every time I ask about sexual behaviors, I also ask about the things that go along with a sexual experience. So we talk about orgasm and whether they're able to achieve that. We talk about lubrication. We talk about pain. And if in fact there is pain, there are a couple of things that I want to know about that pain. And this is a place I think could be helpful for patients to think about before they go into their visit. So the questions that I sort of ask around pain with intercourse: is the pain just at the start of intercourse? So just as penetration is being initiated, is it with deep penetration as well as with initiation? Is it only deep penetration? Is it positional? Are there positions in which you can have penetrative sex that are not painful? Thinking about things like, is it only during a certain time of the cycle that you feel like you're having discomfort with sex? So there's a lot that goes into the concern around painful intercourse that I think requires some teasing out.
Got it. Thank you for that. So another question I have is more just on frequency. So for patients who do not use birth control, and so they don't have the prompt of saying, oh, I'm going to set up another visit so that I can get my prescription renewed. So for those patients not using birth control, how often should they come in for a well woman exam?
So I actually want to start by saying that your well woman care should not be tied to your birth control. Your providers, your clinicians should not be withholding birth control just because you haven't come in for an annual exam. We've seen lots of data in the past to suggest that, holding women to, I'm not refilling your prescription until you come in for your pap test, is probably the most inappropriate use of preventative care that I can think of. But so that's one important point, I think. First, if your physician or your clinician is telling you they won't refill your birth control because you haven't been in a year, find a new one first. What should guide how often you come in is, one, history of pap screening. So we've really changed our approach to cervical cancer screening with pap tests in the last 5 or so years, and we don't need to do them as frequently anymore. And so for most people, we're starting pap screening at the age of 21, and we are doing it at a frequency of about every 3 to 5 years. And so not everybody should or can go 3 years between their visit with their gynecologist, because many other things change in that time. But I think it's a good place to start rethinking what we call an annual exam, because for most women, if they're healthy, they're not having any concerns around their sexual and reproductive health. If they are sexually active in a relationship in which pregnancy is possible, they are either planning for that or preventing that based on their desires. And that doesn't always need retweaking every year. So I encourage patients to talk to their provider about, do I really need to come back next year if everything is fine? For the vast majority of patients, that answer is no.
Wow, that's really liberating to hear. Thank you, Dr. McNicholas. So on the topic of birth control, there's also what some people refer to as LARCs, or long-acting reversible contraceptives, such as IUDs. There's a lot of both confusion and question about them. So I wanted to ask, what are long-acting reversible contraceptives, and what do patients need to know about them?
Well, in my remaining little bit of time, I'm going to give you everything I know about them now. Um, so LARCs are the reversible, as you said, reversible methods of birth control. They are amongst the most effective methods of birth control that we have. Their effectiveness is right on par with permanent sterilization. Obviously, the benefit for people who do want continued fertility at some point is that they are reversible. We have several what we call LARC methods in the United States, and those include IUDs and implants. And the benefit of the LARC device is that for many women, the traditional birth control, which we think of most commonly as birth control pills, are not always so easy to fold into your daily life. For many women who are healthy, the thought of having to remember to take a pill every day doesn't fit so well into life. And so for them, using methods like IUDs, and IUD stands for intrauterine device, or implants, provides an opportunity for them to have sustained ongoing birth control that is essentially user independent. They're devices that we place in the clinic, and then once the patient leaves, they're working, and provided they're not having any side effects or complications, they continue to work for anywhere from 3 to 12 years. I think it's also important for people to know that just because you chose a method that works for, say, 5 years, it doesn't mean that you need to have that method for 5 years. And your method can and should be removed without question at any point when you decide you either don't like it or you want it removed for whatever reason.
Thank you. That's really helpful. And I actually would love to ask a follow-up question about this, particularly as we are, Reproaction is a reproductive justice organization. And just talk to us a little more. So long-acting reversible contraceptives, they don't need to be kept in the whole time. They can be really effective. At the same time, there's a troubling history of certain populations being targeted for long-acting reversible contraceptives, and in particular women of color and young women of color. And I just would love to hear you talk a little bit more how a patient should respond if you feel that that you're being pushed into a long-active reversible contraceptive.
Yeah, so it's a great question. And yes, this country has a long history of reproductive coercion, not just in reversible methods, but also in permanent sterilization as well. And I think, my approach to contraceptive counseling, one of the things that I like to help patients understand is that, there is no right birth control for every single woman, right? And there is so many different aspects of each of the different kinds of birth control that are available. And sometimes not any of those will be right for you. And so I encourage particularly trainees, for example, who are in clinic with me to do sort of a full sweep of all available methods with every single patient, regardless of whether they think they know what they want, or regardless of whether you think you know what's better for them, right? That's a really, as you said, really dangerous place to be, to recommend one specific method for a patient or a patient population without really giving them the option of all the full spectrum of methods. I would say, much like I started the answer to the last question, which, if somebody's refusing to refill your birth control because you haven't been in to see them, I would say if you're feeling at all pressured to choose a method that you are not interested in or you're not sure is right for you, you haven't had, all of your questions answered, then I think that, the best thing to do is find another provider.
Thank you for saying that explicitly. And I just want to underscore that if somebody is pressuring you to use a method of birth control that doesn't feel right for you, you should absolutely find another provider. And if anyone, whether it's a provider or another person, be it a family member or a partner, or for that matter, even someone connected with the state, such as a school counselor or a judge, is pressuring you to use a birth control method, that is categorically wrong. So So just a couple more questions, and then we'll move on to Cicely, and Pamela will lead that part. So just to close the loop on birth control. So for patients who are looking for advice on birth control options, you just laid out really nicely how it's important for the provider to talk through the different options with them. But what information, just personal information, does from a patient, does a provider need to give them the best information and guidance?
Yeah, so some of the most important information that we get from patients that help us to recommend methods that are safe and effective for them are really just basic medical history information. So knowing things, for example, about if you've ever been pregnant before, complications you've had during pregnancy, knowing about whether you've had any problems with blood clots, for example. Those are just some really broad categories that help us as clinicians decide if a method is safe or not for you. There are, obviously in our country, there are tons of issues around financial coverage for contraception. And so many times, and I'll give this as an example, when we saw the suggestion by the current administration that they were going to repeal some of the Affordable Care Act birth control coverage, we saw a huge number of women who, even though their method wasn't yet expired, for example, their IUD, even though it wasn't yet expired, they wanted to come in and get a new one because they knew that then that would get them another 5 years or 6 years to really try and game the insurance company. So in addition to your own medical history, there's tons of different sort of insurance and financial issues that people are also thinking about when it comes to birth control.
Thank you for that. Okay, so my last question for you, and it's kind of a two-part question. So for patients who've had an abortion in the last year, what, if any, difference should they anticipate in their next well woman visit? And then my subsequent question is, what if they've given birth in the last year? So what differences would you expect after having an abortion or giving birth in the last year?
So after an abortion, you should expect nothing different from your annual exam. And one of the most frequent questions I get is, if I go to the doctor, are they going to know when they look? Are they going to be able to tell? And by and large, the answer is no. You can go to your doctor, and if you aren't comfortable telling them that you had an abortion, then you don't have to. They won't be able to tell that. I'd love to say, again, in this instance, find another provider, but sometimes that's not so easy, depending on where you live and your access to reproductive health care. And the same is true of after you've had a delivery. So for many of the things we think about in the post-pregnancy state, whether you've had a miscarriage or an abortion or a delivery, many of the discussions and sort of things that we do post-pregnancy outcome, we've been talking about sort of pre-pregnancy outcome. So for example, birth control and Pap screening and those sorts of things. So there's nothing necessarily unique about having a pregnancy or any one of those pregnancy outcomes that should change the care that you get moving forward.
Great. Thank you so much, Dr. McNicholas. All right, I'm going to pass it back to Pamela to move to the next section in our panel.
Thank you very much. So it is my pleasure to talk to Cicely Paine. Cicely Paine is a sexual health and pleasure educator, a birth doula, a fat femme, and dog aunt based in St. Louis, Missouri. Cicely is also a member of Reproaction's Advisory Council. Hello, Cicely. How are you?
Hi, doing well.
Fantastic, fantastic. So let's dive right in. So as a sexual health educator who has worked with young people and teens, what tips do you have for young people when they go in for their yearly exam? And I guess in general, when they are advocating for their sexual health?
Yeah, so my first bit of advice would be just like a major high five. Any young person who is taking the steps to seek out sexual and reproductive health care, information, resources, whatever, for themselves is, that's a pretty major thing for a young person to sort of initiate for themselves. And so I would first say, like, great job. And then also just sort of thinking about the sort of situations that may lead a young person to be seeking out that sort of healthcare. It may be the first appointment that a young person is going to, not accompanied by a parent. And of course, some young people do go to those kinds of appointments accompanied by parents. But oftentimes it is maybe one that they're going to with a partner, a peer, another trusted adult who is not their parent. And so, just sort of like walking into that situation may feel a little bit daunting because it's often been a parent who's sort of like speaking for you to the doctor or whatever. So thinking about encouraging a young person to think about, that they are their best knowledge resource and their best advocate for their own bodies and their own health, and to be like really like proud of that, and to really use that as a basis to sort of give them like the strength and resolve to kind of make it through that new and different process. Those would be the things I would say.
That's great advice. Thank you so much. So my next question is specific to birth doulas. So what exactly do birth doulas do, and what made you want to become a birth doula?
Yeah, so doulas generally are a support. So there are doulas of many different stripes. There are birth doulas, postpartum doulas, abortion doulas that can provide support in a multitude of situations. So a birth doula's role is really to provide support to the birthing person and their family in the later stages, primarily in the later stages of pregnancy, and then during labor and delivery, and perhaps a bit after delivery has occurred. And so a birth doula's role is really to create the circumstances for really sort of like everything that birthing person and their family is wanting for their birth experience. So they're making a plan for what kinds of ambiance is going to be in the room, what kind of touch that person may want as far as like comfort and care and comfort from the doula, from other family members, making sure that other family members who are present are also taking care of themselves and helping to support the birthing person too. So a birth doula is not a medical provider in any way. A doula is not providing any kind of actual like health care to the person that they're supporting. It is really a position where they are providing that emotional and physical support to the birthing person and family, and then also helping that person to be an advocate for themselves in their birthing situation.
Thank you.
And then,
go ahead.
I decided to be a doula because that sort of piece of really wanting to help support people, particularly people who are at greater risk for poor health outcomes. So I think before you mentioned, that there are certain, or I think with Erin, that there are certain populations of people who are at risk for these poor outcomes. And so, my practice is very much centered around supporting Black birthing people and their families to have the most positive birth outcomes that they can as a doula. So that's how I got involved.
That's fantastic. And since we're both based in St. Louis, and as you know, Reproaction has an infant and maternal mortality campaign that is ongoing in the state of Missouri because Black women and infants face such dire percentage of poor birth outcomes, and just ridiculously high mortality rates. Even it's not about whether or not they've been educated or they come from more money. It really is across the board. So we certainly know how important that work is. And that's actually a perfect segue to a question I had about Serena Williams, the most amazing person in tennis. And Serena Williams has been very forthcoming about a incredibly scary birth experience she had with her daughter, and how she had literally had to take her health in her own hands during labor. And as we know, as we've dived into our infant and maternal mortality work, we found that that is not an uncommon issue for Black women in particular, and women of color, to face higher maternal and infant mortality rates, but also to face just a completely different health experience. So you've explained a little bit about the role that doulas play in patient advocacy, but is it to that extent as well, that if a doula is there and they kind of see a patient not being listened to in that kind of situation, that they would step in and help advocate for that patient?
Yeah, so that can be a little bit of a slippery slope, because it is not a doula's role to be the person who is communicating with the healthcare provider staff in the room. It is really the doula's role and position to support the birthing person to do that advocating and have those conversations themselves. Now, if someone is being harmed, that's not okay. And like any person who I would think, speaking from my perspective, fortunately, I've not been in a situation where someone that I'm supporting is being harmed in any way. But if someone is being harmed, having a support and advocate in the room to be able to say, like, hey, can you not do that, please? I think that would be completely reasonable for a doula to do. That's not the doula's role. If all things sort of like going well or reasonably well in the space, it's really the doula's role to so the doula is a person who is there as support, but obviously has a fairly broad information base about birth. And so a doula is not a healthcare provider, but does have that foundation to go on. And so if something is happening where the doula is like, okay, this is not going exactly how we anticipated it in the birth plan, let me check in with a patient and see if they want to ask any questions about this, if they want to have a conversation with a nurse or a physician about whatever is going on in the space, and really sort of supporting that person to initiate those conversations for themselves, rather than the doula being the person to initiate those conversations.
Got it. Thank you so much for clearing that up. So I'm going to switch over a little bit to talk to people, and specifically from your experience as a sex educator working with younger people and youth, but just people in general struggle with having an open dialogue with their providers about their sexual history. So do you have any thoughts or any advice on how people can open up a dialogue, and then specifically, feeling if they feel the need to get advice or to check and make sure something isn't something to be alarmed about, how do they spark up that conversation?
Yeah. So I think that it is that it's really important for people to sort of to remember and walk into any healthcare situation, recognizing that health of the whole body is real and it's a thing. And even though you may be seeing someone who is, more focused on one particular area of the body or process of the body, that plays into one's whole health. And so if someone is going to a sexual reproductive health care appointment, recognizing that is that piece of their health is a part of the larger picture with their health, I think can be a good place to sort of to start from, thinking about how do I incorporate these questions into what it is that I'm thinking about. Maybe perhaps coming from the perspective of, I'm really thinking a lot about my health recently, and I have a couple of questions about something that's going on, like just as an example. And then I'd go back to something that Dr. McNicholas said a few times during her talk, thinking about like what it feels like to not have rapport with or not have positive rapport with a healthcare provider can make it really, really daunting to feel like you can be open and frankly be vulnerable, because that can be a space of vulnerability, talking about those things with someone who's not like a close friend. And so, it can be difficult to feel like you're constantly just sort of like searching for the right person to bounce those questions off of. But I think that it is a really important point to recognize that, like, if someone is seeing a healthcare provider and that conversation or just the context of the visit feels really uncomfortable or shamey, or they're not really getting their questions answered, or the provider is not making the time and space for them to ask questions, that's probably not going to be the best fit for a provider for them, and they may consider what it would look like to seek out another provider. I think walking into the space knowing that, again, you are the deepest knowledge base and advocate for yourself, that is the space that is designed for you to be able to ask whatever those questions are that you need to ask, and recognizing that if that need is not being met for you, that's like something to consider in whether or not that's a relationship that you want to continue.
Got it. Thank you. And you answered my next question for me, which is really helpful, which was about kind of shaming and some of the problems that patients may face. So thank you so much for reinforcing that empowered position, and specifically for people who live in an environment or a city where they have options, right? It just drives home the need to have options in healthcare. Cicely, thank you so much. If you will hang on till we get to the end, I know that I have questions, and hopefully our attendees have questions as well. If you have questions, please just drop them into the question tab on your GoToWebinar control panel, and I will get to them just as soon as Erin goes through some housekeeping and information about Reproaction. Take it away, Erin.
All right, thanks, and thank you to Cicely and Dr. McNicholas and Pamela. So before we get to your questions, I want to deeply encourage you to continue to engage with Reproaction. So please sign up for alerts at www.reproaction.org. If you are on our email list, you won't miss a darn thing. So that's a great place to connect with us. You can also follow us on social media. We are Reproaction on Facebook, Twitter, and Instagram. And then I also want to encourage you on our website, you can view all of our Act and Learn webinars and download our activism toolkit to take bold action against anti-abortion fake clinics. You can do that just by clicking on resources, and our awesome toolkit on taking on anti-abortion fake clinics in your community is available on our homepage at reproaction.org. So lots of goodies up there. Please sign up for our list. And then the next thing I want to do is encourage you to save the date for our next Act and Learn webinar. We run these every single month. Some of them are more on the self-empowerment side of the spectrum, like tonight. Some of them are really focused on digging deeper into topics, like next month. Some of them are really about sharing strategies about activism and what's working in different parts of the country. So next month's webinar is going to be a really special one. We're going to talk about self-managed abortion. Self-managed abortion is people who are doing their own abortions, and this is a burgeoning field within our movement, and we're really excited to dive into this deeper. So that will take place on Thursday, March 22nd from 7 to 8 Eastern. You can save the date now, and we will be sure to send out the invite. So just sign up for our emails at reproaction.org, and you will be in. And with that, I'll pass it to Pamela for questions.
Yes, so thank you. And I think we might have lost Dr. McNicholas. Dr. McNicholas, are you still there?
I'm here.
Awesome, cool. That's my crazy computer screen. All right, so I don't see any questions from attendees, but I did have a question, so I'm going to take moderator privilege. This one is actually for you, Dr. McNicholas. I have a birthday coming up this week, yay.
Happy birthday.
Thank you, thank you. So I'm mindful that, I am turning 45 and proud of it, and that I started off my life in a different time than we are currently living now. But one of the things that I remember from my 20s is that a lot of my experiences with women exams or reproductive health providers were with people who really lacked a basic understanding of LGBTQ healthcare. And I'm curious if that is something, I definitely have not noticed it in recent years, but is that something that the field of gynecology is addressing, and that, are doctors getting trained on how to understand, and so that people don't feel like they have to educate their doctor? Just curious about that.
Well, it's a great question, and I will tell you that much like other areas of cares within communities that have disparities, I think there are some places where we're doing a better job, and I think there are some places where we're not doing a better job. The LGBTQ communities have been recognized by the CDC and the NIH as sort of special populations, as populations that are essentially being underserved for a number of reasons. One is because of lack of knowledge in the community, and that lack of knowledge comes from a couple of places. It comes from physicians, particularly older physicians, not being interested or not being motivated to learn about taking care of these populations, but it also comes from a real lack of research in the population. There's a couple of reasons for that. I think when people belong to a community that is underserved, and in which there are some real healthcare disparities, along with that comes a real mistrust of the healthcare institution, right? And so we are sort of right now in a place where we recognize the deficit in the training and the knowledge, and we're trying to work on filling that. But like most things, it's requiring a lot of sort of on the ground interaction with the community to build back that trust and to get them more involved in sort of doing the research and learning about their healthcare. So I think there are, and there are places where we're doing really great. I think there's a huge boom now of and focus on particularly trans care. Many of the especially the academic institutions, many of those institutions are sort of trying to really sort of develop these centers of excellence around improving the care that is delivered to the trans population. So I think, I think there is some attention to it. I think we definitely could still do better. I'm glad that you haven't noticed it as much, but probably that's because, as you've gone through life and figured out, as our last presenter was saying, who is a good provider for you and who isn't, right? And so some of that is, you don't see that as much because you yourself have sort of learned who is a good fit for you.
Yeah, very true. Very true. Thank you for that. So this next question, actually for Dr. McNicholas, can you talk about specifically what are doctors checking for during a physical exam and what it entails, particularly if you're not having a pap smear done?
So great question, and I'm glad you asked this. So there is some controversy in the world of gynecology right now around pelvic exams as screening tools. And I co-authored a piece, an opinion piece, in which I argued that, you know, if the patient is asymptomatic, so if you are coming to me for your annual or twice every 2 year, every 3 year exam, you don't need a pap test and you don't need STD screening, that you probably also don't need a pelvic exam. If you don't have any symptoms, there really probably is no good reason for us to be putting our hands and our speculums and those sorts of things in the vagina. And that, I mean, that should make intuitive and good sense to people. So again, I always encourage patients. It's interesting because sometimes when I say that to patients, oh, you don't need a pelvic exam, you know, we've so ingrained in people that they need this every year. They need, you know, there's this moment of sort of taking a step back, like, well, what do you mean I don't need this? But, you know, after you talk through it, there certainly is some understanding there. So, you know, in the event that we do need to do a pelvic exam, some of the things that we check for are, for example, the size of your uterus. So you had mentioned earlier something about fibroids. So if somebody is telling me about, for example, periods that are heavy or painful, one of the things that the pelvic exam might tell me is, well, how big is her uterus? And is there something happening, you know, within the structure of the uterus that I need to be thinking about? You know, certainly STI screening and those sorts of things are also things that we screen for during that time.
Thank you so much. Appreciate that very detailed answer. Thank you. So the next question actually is for Cicely. And I'm just curious, I wanted to touch on this because I think, you know, as much as there seems to be a lot of discussion about how to talk about people's sexual health, one of the things that gets missed, and that I've been pleased to note that outlets like Teen Vogue, and they are amazing, are talking about is sexual pleasure. So when folks are, you know, obviously we're a sex positive organization, and, you know, for people who seek pleasure, we definitely think they should have it. But I don't hear a lot of people talking about that in terms of how, and, you know, empowering your sexual health and empowering dialogues with healthcare providers, or even, you know, people out in the community. So could you just talk a little bit more about, you know, that emerging dialogue about pleasure, and how people can perhaps start that conversation if they are struggling with sexual pleasure with their healthcare provider or with a health counselor?
Yeah. So I think Dr. McNicholas talked a little bit about this, which I'm super glad to hear, that at least in her practice, that she is, you know, engaging all of her patients around those issues. It's really a lovely, proactive thing to hear, and I'm certain that all healthcare providers are not doing that, and so it does kind of become the onus of someone who is perhaps experiencing some issues around that, or at least perceives some issues around that, to sort of initiate those conversations for themselves. And so again, like I don't think that it is always sort of like a common association that sexual pleasure is a part of sexual health, and the outlets like you speak of like Teen Vogue, and you know, and there are a lot of adults who read Teen Vogue nowadays because like they just are doing amazing things, and you know, those kinds of resources are I think are really helping people to be able to sort of see that there is a connection and make that bridge for themselves in recognizing that sexual pleasure is such an important part of sexuality and sexual health and, you know, like, again, overall health. And so, so people beginning to really kind of like have those realizations for themselves, bringing that information to their providers and saying like, you know, I recognize that, like, you know, something is painful. I'm not really experiencing pleasure in the same way I used to, or I don't really experience pleasure at all. What does that mean? To be able to have that kind of basis for like an initial sort of like, I recognize that something is going on now. I can bring that information to my healthcare provider to ask some questions during the time that I have with them.
Thank you so much for that. So I am not seeing any more questions. Erin, did you have any questions?
I can't think of a better way to end than what Cicely just shared about embracing sexual pleasure as part of sexual health and overall health. I found that to be a mic drop moment. I would have more questions, but I don't want to because that's just a great ending.
Hear, hear. I totally agree. So I would like to take this opportunity to thank Dr. McNicholas and Cicely Paine for joining us on tonight's webinar. I'd like to thank our attendees, and thank you as always to Erin for being a fantastic co-director. And we are ending on time, which is a Reproaction tradition. So I hope everybody has a wonderful evening, and we will see you in the streets if we don't see you on another webinar. Thank you so much.
Thank you.
Thank you.
Good night, everybody.